much. So this is the second of our sessions today at the first Nursing and Allied Professional Research University Day. We're very excited to be presenting to you today. The first thing I'd like to do is just to go over some of the housekeeping aspects, if that's okay. So Rosalie, if you could share that slide, please, that would be amazing. That's wonderful. Thank you very much. So we'd love to hear your questions. If you have any questions at any time throughout the presentations, please use the chat on the right-hand side of your screen, and I will do my best to read all of those out. If not, at the end of the individual presentations, at the panel Q&A at the end of the session. We have 3 presentations for you today. The first presentation in this session is recorded. So following the end of that session, we'll move straight on to the second presentation. After the end of the second and third presentations, there'll be an opportunity for all of you to ask any questions that you may have. At the end of those sessions, and also we've got 3 of our colleagues from intensive care coming to share their experiences of implementing the AF guidelines that we'll be talking about today. We'll have around about a 20-minute panel presentation. You can raise your hand if you want to ask a question in person. Otherwise, please feel free to use the chat and we will read that out for you. Finally, just to remind you that we will be recording the event. It's currently recording as we speak at the moment, and we'll be tweeting some aspects. So please do feel free to share and promote on there too. So moving on to the first session. Thank you very much, Rosalie, for sharing that slide. That's great. I'd like to introduce the first speaker, who is going to be talking about the Society of Cardiovascular Anesthesiologists and the European Association of Cardiothoracic Anaesthetists Practice Advisory for the management of perioperative atrial fibrillation in patients undergoing cardiac surgery. And it's really all to do with the implementation for nurses and allied health professionals. The first speaker today is Professor Benjamin O'Brien, who is a Professor of Anesthesiology and Intensive Care Medicine. He's the Director of the Departments of Cardiac Anesthesiology and Intensive Care. Oh, sorry. Sorry about that. The screen popped up in front of me. So Intensive Care Medicine at the German Heart Center in Berlin and the University of Berlin. He's the chair of the Cardiac Anesthesiology and Intensive Care Medicine at the Charité University and is an honorary professor of perioperative medicine at the William Harvey Research Institute here in London. Professor O'Brien's research focuses on cardiovascular perioperative medicine with an emphasis on patient outcome-based research. His research groups and collaborations in London, Oxford, Boston, and Berlin focus on the prevention and treatment of heart rhythm problems following cardiac surgery. He's considered an expert in the field of atrial fibrillation after cardiac surgery and has authored international guidelines, leads randomized trials, and coordinates data science projects using machine learning and artificial intelligence techniques. Professor O'Brien also collaborates with transitional scientists to bring laboratory-based research to the bedside. He also serves on the editorial board of the Journal of Cardiothoracic and Vascular Anesthesia and provides peer reviews for several other professional journals, funding bodies, and appointment committees. And Gaston, thank you very much. If you could now go ahead and please play Professor O'Brien's presentation, that would be fantastic. Thank you very much. And to our audience, please feel free to pose questions at the end for the panel. Just a reminder that this is a pre-recorded presentation. Thank you very much.
Hello, dear colleagues. I hope this finds you well in rather unusual times. My name is Ben O'Brien, and I've got a long-standing research interest in atrial fibrillation after cardiac surgery, AFACS. So I'm grateful to the organizers for the opportunity to introduce you to the Society of Cardiovascular Anesthesiologists and European Association of Cardiothoracic Anaesthetists Clinical Practice Advisory on atrial fibrillation after cardiac surgery. AFACS is the most common complication after cardiac surgery, affecting around a third of patients after coronary artery bypass grafting, about 40% after valve surgery, and half and more after combined procedures. It is very much a perioperative problem. Out of all patients that will develop AFACS, 70% will have done so before post-op day 4 and 94% by post-op day 7. By no means is AFACS a benign complication. It carries increased morbidity, in particular an increased stroke risk, increased mortality, increased length of stay, both in the critical care unit and in hospital, and consequently increased cost of care. This is a typical marginal gains area where, in the absence of a golden bullet that will take care of AFACS once and for all, small improvements through good application of the evidence can make a big difference. So modeling this on publicly available data from the US and the UK, we chose data from the year 2013, for every 1% of reduction in the incidence of AFACS, we would have 3,000 more AF-free patients, and we would save 15,000 hospital days. So the take-home message number 1 is that atrial fibrillation after cardiac surgery, AFACS, is common and it is relevant. To set the scene for our practice advisory, we administered the, to our knowledge, biggest practice of worldwide, the biggest survey of worldwide practice to date. And as you can see, the geographical coverage of our responses covers many areas of the world.
Perfect.
On the right, you'll see the citations for the 2 publications of the practice advisory, including the survey. From this survey, we found that there's a huge variability in practices. And there are more than a dozen therapies that are routinely used by members of both societies that carry either no evidence base or conflicting evidence. So the take-home message number 2 is that clinical practice is highly variable and not in line with current best evidence. Which then led us to accumulate the existing evidence, like a meta-analysis of guidelines and evidence, and to bring it together into a readily accessible format for practitioners. More background on this undertaking can also be found in the podcast that is available on the SCA website. So if you Google SCA, AF, and podcast, that should bring you to the little symbol that you can see here. At the heart of the publication is this graphical practice advisory, and I would like to take you through the various aspects of it now, step by step. The real focus in AFACS has to be on prevention, and we'll spend a bit more time on that. So in the meantime, let's start with treatment, where really there are only 2 interventions that carry class 1 evidence, namely to use calcium channel blockers or beta blockers for rate control. And in the case of hemodynamically unstable patients, cardioversion is recommended, be that electrical or chemical, for example, with amiodarone. There are 2 further interventions for the treatment of AFACS that carry class 2A level of evidence B. One is for amiodarone for rhythm control in the absence of hemodynamic instability, and the other is to consider anticoagulation when the duration of AF exceeds 2 days or 48 hours. Moreover, there are 4 additional therapies with only class 2B recommendation. They are Soltalol, intraoperative biatrial pacing, postoperative corticosteroids, and post-op colchicine. So the take-home message number 3 relating to treatment of AFAX is to cardiovert if the patient is unstable, and to use calcium channel blockers or beta blockers for rate control. Which brings us to prevention of AF after cardiac surgery. And you can see here in yellow that there is one class 2A evidence about prophylactic amiodarone. So the usage of amiodarone before the operation, during the operation, or after the operation in patients who have not yet developed AFAX. All the other evidence around the prevention of AFAX relates to the use of beta blockers. So to avoid beta blocker withdrawal, those patients that present in beta blockade should have beta blockers continued throughout their perioperative stay. And in beta blocker naive patients, beta blockers should be administered as soon as possible postoperatively. The subsequent speakers will take you through this little project where we really looked at our own perioperative beta blocker practice at Barts. So I don't want to steal their thunder, but suffice to say that with disciplined usage of current best evidence in beta blockade in patients in the prevention of AFAX, a significant dent can be made in the incidence of AFAX. So the take-home message number 4, dealing with prevention, is that prevention is key, and be disciplined regarding the beta blocker practice, as the subsequent speakers will explain. The eagle-eyed amongst you will have noticed that the practice advisory stratifies between patients in normal risk and patients with an elevated risk for the development of AFAX. That merely reflects the fact that the current literature has this stratification. Interestingly, though, there is no validated risk predictions tool in order to stratify an individual patient into one of these 2 groups. There is a current NIHR-funded project that will look at risk prediction of patients both preoperatively and then again upon arrival to the critical care area after the operation. But in the absence of a current validated tool, please consider these 6 risk factors: age older than 75, a history of AF, renal failure, mitral valve surgery and disease, heart failure, and COPD. If any of those 6 risk factors are present, or more than one of those risk factors are present, then you can deem the patient to be at increased risk for AFAX. And it might be that more aggressive prevention with amiodarone, for example, is reasonable. So in summary, AFAX is common and relevant. Clinical practice is too variable as it stands. We would urge you to estimate individual patient risk and then consider amiodarone for prophylaxis. Prevention is key, and be disciplined with beta blocker practice for prevention. And the treatment, if there's hemodynamical instability, cardiovert, and if not, then employ a rate control strategy with calcium channel blockers or beta blockers. Thank you very much.
Listo, Elvis. Puedes dejar de compartir el video.
Thank you very much, Gaston. I'd like to thank Professor O'Brien for taking the time to record that presentation for us, and I'm sure you all found it as interesting as I did. As I informed you earlier, it's a pre-recorded presentation. Therefore, if you have any questions, I'm sure that one of the panel members will be able to answer that question at the end. Therefore, moving on, I'd like to introduce our second speaker today, Dr. Dylan Wells, who's going to be talking about the management of perioperative atrial fibrillation. So I'd like to introduce Dr. Dylan Wells, who is a clinical fellow in paediatric surgery at Great Ormond Street Hospital. He's previously worked in cardiac intensive care at St. Bartholomew's Heart Centre, where he was involved with the perioperative care of cardiac surgical patients. He has an interest in quality improvement and optimizing medical systems to improve patient outcomes and experience, and he is hoping to pursue a career in cardiac surgery. So, Dr. Wells, I'd like to hand the floor to you. Thank you very much.
Good morning, everyone. Let me quickly share my screen. Can everyone see? Fantastic. So my name is Dylan Wells, and I'm going to tell you a little bit about a project I was involved with at St. Bartholomew's in the cardiac ICU. We called our project Doing Simple Things Well, and we thought this was a really good title as it encompassed what we were able to achieve with a really simple intervention. And like what Prof. Brian has alluded to, it was just an application of guidelines. And here you can see who else was a part of the team that did the project. So AFAX, as Prof has alluded to, is the most common complication following cardiac surgery, and it affects between 30 and 50% of all patients. Certainly a perioperative problem. And as Prof said, we see most patients who are going to go into AFAX having done so by post-operative day 7. But the peak incidence is in post-operative day 2 and day 3. Obviously, AFAX is an important issue, increasing morbidity, mortality, and hospital stay. And as Prof said, it increases your risk of stroke, cardiac instability. And often it means you have to stay in hospital, not only for management of your illness, but possibly also while we get anticoagulation up to therapeutic levels. We all know the struggles and the time it takes to get warfarin to a therapeutic level. So we wanted to see how we were doing and how we compared to international literature. So we did an audit. We took a 6-week period in 2018, and we looked at the rates at St. Bartholomew's of AFAX following CABG, valve surgery, and overall. And we found that this was really in keeping with published data. We were 31% for CABG, whereas the published literature says 30%. For combined, or not combined, for isolated valve replacements, we were 45 and 42%, whereas the literature says 45%, says 40%. So we really are comparable to what's happening in the rest of the world. Next, we asked ourselves, what can we do about this? We knew about the guidelines that Prof. Brian has spoken through, and we had a good look at them and about how we could apply them better to our situation. In particular, we looked at the first 3 recommendations, the 3 class 1 recommendations. And these point mostly to the use of beta blockers in patients, both for prevention and treatment, and the use of cardioversion, both electrical and chemical. And this is what we focused on and trying to apply this to our situation. We had a relook at our audit data, and we saw that while our overall incidence of AFAX was only about 35%, in patients who had beta blockers both pre and post-operatively, AFAX was a little bit reduced at 34%. In patients who were beta blocker naive throughout their perioperative period, incidence was 44%. But really worryingly was that patients who received beta blockers preoperatively and not post-operatively and an 80% chance of going into atrial fibrillation. This was something that really struck us. And as a team, we looked at this and thought that there has to be something more going on here. And we can't just accept that these patients are not getting their beta blockers early, as this is certainly a population where we feel we could make a difference. Next, we looked at implementing an AFAX prevention care bundle using the Model for Improvement framework. We knew what we wanted to accomplish. We wanted to decrease the incidence of AFAX. We knew how we were going to do it, and we were going to look at ways to better apply the already well-established best clinical practice guidelines. And we didn't know whether this was going to work. So we knew we'd need to come back and have a look at the data after our implementation. And that's really what we did. We looked at applying the guidelines. So what we did is we developed or formed a multidisciplinary team. This was a team with anaesthetists, cardiothoracic surgeons, ICU doctors, and most importantly, nurses and pharmacists as well. We tried to come up with an easy to see and recognize graphical tool where someone would be able to follow through our framework for best practice and apply this easily and simply in the patients it was going to make a difference to. Next, we presented our ideas and had a discussion with all the stakeholders involved. The last thing we wanted was to do all this work and not have good implementation or uptake in the wards because someone had an issue somewhere along the line. So we made sure we had an extensive consultation process before implementation so that everyone was agreeable with our goals and the way we were trying to achieve that. Here's a picture of what our care bundle looked like, or still looks like. You can see we've broken it into 5 large domains. The first domain looks at beta blockers, and particularly at starting beta blockers early in the postoperative period, even when they're on cardiovascular support. So as long as a patient wasn't on multiple inotropes and they were on less than 0.05 mics per kg per minute of NORAD, we were happy to start beta blockade. We accepted that while beta blockers would certainly bring down their cardiac rate and drop their blood pressure a small amount, we felt that the gains for preventing atrial fibrillation were far more important and that the other risks could be managed quite easily on a cardiac ICU. The rest of our domains focused around baseline ICU care, about optimizing electrolytes, ensuring adequate fluid balance, minimizing pain, and reducing hypoxia. And these are things we should all be doing anyway. It was just a friendly reminder to say that these are important for atrial fibrillation as well as basic ICU care. Next, we had a long implementation period where we printed out posters of our care bundle. We had colorful laminated sheets that we placed at every bedside, and we had teaching sessions for the nurses and the medical teams. Fundamental to our good uptake was the teaching of the nurses. Often the doctors rotate every 6 or 3 months as training posts move. But the nurses provided a continuity in the ICU that we weren't able to get from the medical team. Our education sessions allowed nurses to take charge of the implementation of the beta blockers. It meant that they were often able to advocate for early beta blocker administration on the ward round, and they knew the guidelines, and they knew when it was appropriate to start them. And often they'd be the ones who'd prompt the medical teams and remind the consultants that this was something that was important. And then lastly, we also sent out multiple reminder emails to the consultants so that everyone knew that the project was still ongoing and still important. So how did we do? A year later, we had a re-audit. We looked again at a 6-week period, and we compared the patient demographics from our first audit to our re-audit. and we found that we had a statistically similar patient population with no major differences in age, gender, or the type of surgery, or their baseline function. And this was really important to us so that we were able to compare our data from both audit cycles. We found that initially beta blockers were given to 83% of patients, and that in a repeat audit, beta blockers were given to a whopping 91%. So certainly an improvement there. We also found that beta blockers were given earlier, and this was really important for us. As I said earlier, the peak incidence of AFAX is in days 2 and 3 post-operatively. This means that if we want to give a medication that's going to prevent AFAX, we need to be intervening on day 1 so that it has time to work. This is also how we know that there was good uptake of our project, as this was a major change with almost twice as many patients receiving beta blockers on post-operative day 1. Unfortunately, it's not always possible to give them any sooner than that. We found that the incidence of AFAX was significantly reduced. We managed to reduce AFAX incidence from 35% to 23%. And you can see here by the p-value that this is statistically significant. We were able to decrease the incidence of AFAX on all post-operative days, but particularly focusing on days 2 and 3. This reduction means that 191 patients each year will not develop atrial fibrillation following their cardiac procedure, and that's just in one center. We found that we were able to reduce AFAX incidence across all age groups, with a particularly marked reduction in the 65 to 75 year group. We found that we were able to reduce the AFAX incidence significantly for both CABG and aortic valve surgeries. Unfortunately, the data of this doesn't hold true for combined CABG valve replacements, as well as isolated mitral valve surgeries. This was due to numbers of patients that received these interventions, as well as a slight difference in the pathophysiology of atrial fibrillation in these patients. We did an analysis of the barriers to implementation. And we found that one of the big things, one of the biggest reasons why patients didn't receive beta blockers on day 1 post-operatively was that they were too ill. And you can see by this graph that the majority of the patients on day 1 who didn't receive beta blockers was because they were on multiple inotropes or they were on a high dose of noradrenaline. This decreased as we would expect over the post-operative days, with day 5 only a few patients remaining on inotropes and vasopressors and still not getting their beta blockers. But we'd picked up on so many of the other patients who were also at risk. Why does our scheme constitute good practice? We know it follows best practice guidelines as set out by the European Association of Cardiothoracic Anaesthetists, as Prof. O'Brien has explained. It's something that was fully applicable to our patients. We had a high incidence of AFAX of 35%, and we saw that we were able to reduce this through a very simple intervention. We're very proud that we involved multiple members of multiple disciplines within our team, and it wasn't just a doctor-led initiative. It was developed and discussed with all stakeholders early, and this meant that it was sustainable, even through doctors leaving the trust and moving on to other endeavors. It also focused on something that was easily measurable and something that made a real difference to our patients. While we didn't prove that we were able to decrease hospital stay and length of time, we did make a big difference to the number of patients that developed AFAX. Ultimately, what we did worked, and it made a difference to the patients. We were able to change local practice during our implementation period, and this has been something that's persisted through because of our positive results. It's something that's still being used and is still sustainable because of the way we we went about it. I think this is something that could be applied very easily to multiple other situations and in multiple other hospitals. And hopefully this is something that will manage to reduce patient complications, morbidity, mortality, and ultimately reduce hospital expenditure. Thank you.
Thank you very much for your presentation, Dr. Wells. That was really clear and informative, and there's been lots of comments coming up throughout, and I'm going to ask you some questions if that's all right. So one of the questions is, Dr. Wells, have you explored the use of amiodarone prophylactically pre-op, similar to what Prof. O'Brien mentioned during his session?
So we did discuss this with the stakeholders early on when we were looking at putting together the care bundle. There was some concern over the toxicity of amiodarone, as it's certainly not a benign drug. And also we were concerned about how we'd be able to risk stratify the patients into high and low risk. Prof. O'Brien spoke about the 6 risk factors, but with the lack of a consensus risk score system, we felt that it was inadvisable to do this in our patients. So what we did is we focused on a safe intervention that we had already put into place and about optimizing that with our patients. And we found that just with doing that, we were able to get fantastic results. Hopefully this will be something we can look at in the future, especially since Prof alluded to the fact that they've got a project underway to try and develop a scoring system. I think that'll be invaluable in treating AFACs in the future.
Thank you very much. Someone else has posted, they've said, what about phosphates? Lyrill, did you want to come and expand on that question? Or she said, like potassium and magnesium, do you keep phosphates within a limit?
So it's not one of the routine electrolytes that we optimize, but it's certainly as part of baseline ICU care, it is something that we would replace if we were concerned that it was low. It didn't form part of our particular care bundle, but it should form part of any critical care.
Great, thank you. So another one, sorry, I'm going to bombard you with lots of questions here, if that's all right. It's been popular. So it's clear that there's significant improvement to the management of AFACs as a result of your research. What is the next step for you and your research, please?
So I think the next step is trying to see if we can apply the same implementation and get similar results in other settings. And there have been a lot of other hospitals that have reached out to our team to try and do this. And I think that's something that's really promising. I think also we need to look at trying to get an AFAC scoring system validated in a way that we can meaningfully apply slightly more invasive therapies to these patients and hopefully further reduce the AFAC's burden. And Prof. O'Brien has alluded to this. I think also this would allow us to be more aggressive and to use things like amiodarone in the patients that were at risk beforehand.
Lovely, thank you. Another question, did you have increased incidence of bradycardias or pacing requirements following the beta blocker usage?
This was unfortunately not something we looked into with our data, but I saw there was another question about PR intervals, and one of our limitations to starting beta blockers was a bradycardia less than 60. And if they developed a bradycardia, we then stop the beta blockers as well. The beta blockers were meant to be something that was auxiliary to the care, but as soon as they became unstable, there was the possibility that it was impinging on their hemodynamics. That then sort of superseded us in a preventative capacity, as patient care needs to come before prevention.
Oh, fabulous, thank you. And I think you've answered Carol's question as well there about the PR intervals. So thank you very much for your time today, and good luck with getting your scoring system validated when you move on to that phase of your research. Thank you for your time. And Thank you. I shall move over to your colleague, Dr. Martina Bursch, who is our second speaker for today. Dr. Bursch trained as an anaesthetist in Munich, Germany, where she further specialised in cardiothoracic anaesthesia and critical care. She's worked in several major heart centres in England, and since January of last year, she's been working as a locum consultant in cardiothoracic anaesthesia and critical care at St. Bartholomew's Hospital, sorry, I can't speak, at Bart's Heart Centre in London. She's involved in quality improvement and research, as well as multidisciplinary teaching in the field of cardiac perioperative medicine. Therefore, Dr. Bursch, I'd like to hand the floor over to you. Thank you very much.
Thank you for the kind introduction. Just if you confirm you can hear me well and see the slides I'm sharing.
Yes, I can hear you and your slides look great. Thank you.
Fantastic, thank you. Good. So thank you for this introduction, and I'll follow up on Dylan Will's talk and focus a little bit more on how to implement change and improvement in general, but using our successful project, the AFAC care bundle in implementation in cardiothoracic patients as an example for this. So come off the slides right now. Yeah. So I'm just going to very briefly recap what Dylan just presented in much more detail, and what you've heard about from Prof. O'Brien about atrial fibrillation after cardiac surgery, or AFACS, which is the most common complication after cardiac surgery, is a very early postoperative problem. And despite evidence-based guidelines, several of which have been in place for many years, the incidence of AFACS has not really changed and remains the most frequent complication. So this is to very briefly summarize what Dylan just presented to us in more detail, our prevention care bundle, our results in terms of beta blockers that were given to more patients and earlier, and subsequent to the implementation introduction of the bundle, our AFACS incidence in our center significantly decreased. So now I'm going to talk in this presentation about prevention care bundles in general, or how to design them, and then to implement change. So prevention care bundles are defined as a small set of evidence-based interventions for a defined patient population and care setting. They're particularly useful when the problem to be addressed is multifactorial. And the first prevention care bundles, or care bundles, I think that were known, have been introduced in intensive care medicine. So things like a central venous line care bundle or a ventilator care bundle that you might have heard about. And they've been shown to prevent serious adverse events experienced by ventilated patients or patients with central venous access. And this is an example of the IHI central line bundle, which was introduced years ago, published here in 2012 by the IHI, which is the Institute for Healthcare Improvement. For those who are not familiar with that, we'll talk about this and about their methods later in the talk. So it is an American institute that promotes quality and safety in healthcare, and they've come up with a lot of quality improvement methodology, and they've created, for example, this central line care bundle, which consists of 5 items: hand hygiene, maximal barrier precautions, chlorhexidine skin antisepsis, optimal catheter site selection, and daily review of line necessity. So those of you who work in intensive care unit might have come across this and the things that we have adopted from this bundle. Another more recent prevention care bundle from our hospital, and I think we heard earlier about certified infection prevention, is this one, which again has 5 items: use of device to improve sternal stability, antibiotic prophylaxis, blood sugar control, use of negative pressure wound therapy dressing, and do a photo at discharge. So I'm sure, I mean, there are many other bundles nowadays around, and I'm sure that there are other bundles that you come across, maybe in intensive care, maybe in other areas, maybe in cardiothoracic surgery, maybe in other areas of healthcare and hospitals. Well, looking at those bundles that I've just shown you, and perhaps the ones that you've got in mind, thinking about which bundles you've seen, often it sounds like this is obvious. Anyone does it anyway. I mean, everyone cleans their hand before they put in a central lamp, right? Or everyone cleans the patient's skin before proceeding to surgery. Well, I've learned to never assume things like this. And this is Ben O'Brien's team publication and the survey that he mentioned in his talk. And respondents from the Cardiothoracic Anesthetic Societies were asked how the HA class 1 level of A guideline, which is a very high level of recommendation that recommends prophylactic postoperative beta blockade to reduce risk for postoperative AF, affected their clinical practice. 79% of all practitioners believe that they follow this guideline either sometimes or nearly always. Right, that sounds very good. Still a bit room for improvement, but very good already. However, if you look at their detailed survey results, and this is the postoperative beta blocker administration that respondents on the y-axis, percentage of respondents applied to percentage of the patients on the x-axis. And you can see that that around 30% of respondents, the blue is the American Society of Cardiothoracic Anesthetists and orange is the European Society, but from both societies, around 30% of respondents gave prophylactic beta blockers postoperative only to 0 to 10% of patients, and only a third here and less in the European group gave it to 90 to 100% of patients. So that doesn't really fit too well with the almost 80% of practitioners who thought they were actually following the guidelines. So this, I think, is probably something that you come across in various domains and areas. And I think it's good prerequisites to think about a prevention care bundle to tackle this issue. If you've established that A, there is some medical evidence or guidelines that already exist, or there's evidence that does exist, you don't have to research for a new treatment first. It already exists. You also have established there's a significant non-compliance with it. And the problem is multifactorial and or different elements are playing a role. So what next if you want to tackle this issue by using a prevention care bundle? So again, the IHI have come up with some bundle design guidelines, which they have researched and tried and gathered some evidence that this is how it best works in their experience. So the bundle has to have 3 to 5 interventions or elements, so not too few, otherwise probably won't be a bundle really, and not too many. And they should all have strong clinician agreement. Each bundle element should be relatively independent from the others. The bundle should be used with a defined patient population in one location. The multidisciplinary care team should develop the bundle. Bundle elements should be descriptive rather than prescriptive to allow for local customization and appropriate clinical judgment. And compliance with bundles should be measured using an all or none measurement with a goal of 95% or greater. So I'm going to go through these guidelines and look at what we did compared to what they recommend. So they also say, the IHI, the bundles were not intended to be comprehensive care. Rather, they were developed to test the theory. That is, when compliance is measured for a core set of accepted elements of care for a clinical process, the necessary teamwork and cooperation required will result in high levels of sustained performance, not observed when working to improve individual elements. And you can discuss this a bit later. I think that's a very crucial part of our project and similar projects. So let's have a look at our bundle again, and you've gone through it with Dylan earlier in his presentation, and have a look. Let's have a look how we did follow the care bundle design guidelines. So first they say 3 to 5 interventions. Okay, so we've got 5 interventions, so that fits in very nicely with strong agreement and stakeholder involvement, as Dylan presented earlier. We've got all this. Then they say each bundle element is relatively independent. So I would say they're all independent. Beta blocker administration has not much to do with electrolyte levels, has not much to do with fluid balance, and not with pain management and postoperative hypoxia. So they're all independent items. Different from, for example, if you put first element tight blood glucose control, and then you choose as a second bundle element measure blood glucose every 2 to 4 hours. That's probably not very independent. Instead, if you focus one element, for example, on blood glucose, and the next one on something else that is relevant for your issue or your the thing that you want to address, blood pressure measurement or antibiotics or something like that. Next one is you have to use it for a defined patient population in one location, or create it for that patient population in one location. So we stated quite clearly what patients it would apply to, CABG, valve, or combined procedures, which setting, the adult cardiac care unit is in our hospital. It doesn't say here, but that's what it's meant to, where it's meant to be applicable to, and the time frame applies to. Next one, the bundle elements should be descriptive rather than prescriptive. So let's have a look at this. I would say 3 of them are clearly descriptive and not too prescriptive. So even though for the beta blocker administration and initiation, reinitiation, we set quite a few criteria that need to be met. However, we don't say which beta blocker, which effect drug to use, and what dose. And also, early, we say as early as possible, but we don't set a time. And equally for fluid balance, we don't set a fluid balance target. We say avoid overhydration or too aggressive diuresis. Same for pain management. We don't set a certain drug or dose. A bit different for the electrolytes, magnesium and potassium, where we not only set targets, but also what to do if the targets aren't met. So what to give and how much of it. So that's more prescriptive, I would say. And then a very important point is that multidisciplinary care team develops the bundle, and Dylan pointed out and then explained that earlier. So we had one ICU cardiothoracic nurse in our team, 2 anaesthetists intensivists of very different grades, plus 1 ICU junior doctor, 1 cardiology trainee, and 2 cardiothoracic surgeons, again different grades, and 1 pharmacist in our team. So this is truly multidisciplinary and multi-professional. And then the last one, bundle design guideline item says compliance with bundle is measured using all or none measurements with a goal of 95% or greater. Okay, this one I don't really know. we've measured the beta blockers. We've measured the first element of our bundles, and we've seen that we were able to increase the use and improve the use. However, we haven't really measured, and I think that was something that was one of the questions earlier after Dylan's talk. We haven't really measured the other elements of the bundle, and therefore we haven't measured the overall compliance with the bundle. Also, we had an impressive increase in beta blocker administration. However, it didn't reach 95%. We can, if you want to discuss this further in the discussion, why we did it or why we didn't, and how we could have done it. Okay, so this is the first part about how to create a bundle and just a presentation of some guidelines that exist for that. So I've created one now, or developed any other change idea or suggestion, what to do now. So this is about implementation of a quality improvement project in general, not only for bundles. I'm just using our bundle as an example. For a multidisciplinary QI project. And we'll go a little bit into implementation science and theories. So this is what Dylan already mentioned, and I'm sure you've all heard about and are quite familiar with, the model for improvement, which is again being developed by the IHI. And although there are several other models to be used for improvement in healthcare and quality improvement in healthcare by other organizations, this one is the one that is most often used nowadays in the NHS, I think. So everyone is very familiar with the Plan, Do, Study, Act PDSA cycle. However, sometimes it gets forgotten, my impression, that the first three steps that come before the PDSA cycle are equally important, if not even more important, to get a really good quality improvement project. So I'll go through them in a so I'm going to go through them into a bit more detail. What are we trying to accomplish? It's the first question that we need to ask ourselves. How will we now know that there are changes and improvements? And what change can we make that will result in improvement is the third question. So to the first one, what are we trying to accomplish? We need to set an aim, how and by when. And you all know from work, university, or even your private day-to-day life, that we all have got ideas, and we want to do more exercise or get to work more on time or avoid the daily traffic jam or something like that. And we very often don't really manage to change, because very often we don't really say how we're going to do that and by when. So we just want it to happen, but we don't set any deadlines or anything. And in comparison to other projects that we do, for example, for studies, university, things like that, we do set deadlines and targets, and suddenly these things do work out, whereas we're still not exercising as much as we want to do. So this is extremely important. How will we know that a change is an improvement? So we need to establish measures, and I'm going to go through this in a little bit more detail in a moment. And what change can we make that will result in improvement? So we need to determine changes to be measured. Which changes do we need to make to achieve the aim that we set in the first place? Then number 4 comes the PDSA cycle to test the changes. And then number 5, which is also very, very important, to implement the changes. So all efforts that we do to implement it. It's very nice if we've done, we've thought about the project, about what we're going to do, why, and then planning, doing, studying, acting, and everything, works all right, it looks all good, and then we just leave it there, and we haven't, managed to implement it as a sustained way of doing things or change. So this is equally important, and it needs a lot of effort sometimes, because it's nice to present to the audit and a QI project but then in a meeting or something, but then if nothing happens, that's this waste of energy and time. Okay, so let's have a look how we went about for this AFACS bundle project using the model for improvement. So what set a name, how and by when. So we wanted to reduce the incidence of AFACS in our patient population by using adherence, by improving adherence to guidelines and by using a bundle. And by when? Within the next 6 months. And they're quite clear aims. Establishing measures. So I'm going to talk a little bit about this. So it is important to understand that QI is not research, although it has got some similarities and some methods are similar. QI is real world, there's no control group, and instead it consists of rapid sequential tests, and we do accept bias. So many people overcomplicate quality improvement projects by trying to achieve very high numbers, statistical methods, and things like that, which is all nice and fine. We did for our project have actually quite high numbers, and we were able to do statistics with them. However, this is not needed really, because we don't have to prove that a new treatment works, because we are looking into things that have already been proven in science and research to work. And clearly there is some overlap, and I think in the first session we clearly see that there's overlap in quality improvement and research, implementing things from research that we know don't work very well, and studying why they don't work very well in the real life, in the real world. However, it is I can only encourage everyone who wants to embark into quality improvement and not to be distracted too much about research methodology, but just keep it very simple and accept bias and other things that wouldn't be accepted for research. It's just the aim is a very different one. So these are the main 3 types of measures that we use in the model for improvement. So outcome measure is the measures that tell you how the system is working. So the ultimate result, which in our case was the incidence of AFACS and on postoperative day 1 to 5. Second one are process measures, which tell you if parts or steps in a system are performing as planned to affect the outcome measure, the overall measure. So with our project, that would be beta blockers given or potassium levels, for example. And then third one are balancing measures, which assess whether changes to improve one part of the system may introduce problems elsewhere. So I think this is one of the things that one participant asked earlier about the incidence of severe bradycardia. You might have reduced the incidence of AFACS, but with the cause of having more bradycardia, more severe bradycardia. Also, we might have, by introducing our bundle, we might somehow have influenced other factors impeding ICU discharge that we didn't think about, that we didn't know about. So it's good to have an idea of what we actually influencing by changing something. So this is to recap. So this beta blocker given and how much and how early, it's really a process measure that we use to see whether we thought the bundle was going to be followed and the steps were going to the items that were followed. So then the third part, determine the changes to be measured. So which change do we need to make to achieve the overall aim? So for that, you need to get a bit creative and just find ideas from elsewhere. So read books, papers about this topic, talk to experts, to other hospital teams, also teams who are doing similar, who've got similar ideas, but in different areas. Ask the front line, including patients and families. Anything to just get some ideas. And for the AFACS project, we took the recommendations from the previously published practice advisory, the one that Ben O'Brien presented in his talk. And we looked at areas described there with poor adherence and we picked those areas we thought we can improve there. And also they recommended that you could see a graphical tool. So we thought we will develop a graphical tool. And number 4 is test changes. So plan, do, study, act cycle. Plan by whom, where, when, how, which stakeholders to involve. And I think you heard a little bit more about it in Dylan's talk earlier. Equally for what we did. So we did teaching of nurses, doctors, pharmacists, we sent around emails, we printed, laminated, and distributed the bundle everywhere. Then we studied, we did the data collection and re-audit, as you heard before, and then act. So adapt, adopt, or abandon. So there might be things that haven't worked, which you can abandon straight away. You've tested them and you don't need to do it again if it doesn't work. Adopt things that work very well, and adopt things that might have shown a little bit of success, but clearly need improvement. So we collected, for example, reasons for non-adherence, as Dylan showed you, in order to address barriers in the next cycle. And also we collected patterns, CABG versus mitral valve surgery, to address a population where maybe this funnel wasn't followed as well as in other populations. This, I just wanted to show you that there are other approaches, and in the end they're quite similar, but this is from the AHRQ, which is another institute that promotes quality in healthcare. They came up with a 4E strategy, which says engage, win the hearts and minds of your team, educate, teach your team about your intervention, execute, implement your plan with purposeful team participation, and evaluate, determine how well your effort has improved care processes and outcomes. And as you can see, I mean, there's a lot of focus on the team, really. So win the hearts of your team, teach your team, and team participation comes up in every single step, really. And also that you need to adjust your strategies depending on your stakeholder. So number 5, which I said was equally important to have sustained change. What we're trying to do, and in the process of doing, is to develop local SOP where this bundle is integrated or integrated into existing SOPs in our hospital. To continue doing re-audits, use them and the use of the care bundle, and a number of the incidence of AF after surgery as a marker of quality of care. And then you can also take it a step further to share it with other centers nationally, internationally, and conferences such as this one, NCBC, which is the National Cardiac Benchmarking Collaborative, which exactly projects like this are discussed and shared between different centers. Societies, you can publish, and various media, you can exchange ideas through platforms like LiveQI, which is a college improvement platform that is very easy to use, and many hospitals and trusts in the NHS nowadays use, and you can easily get ideas from others and share your ideas with others. So what we are planning to do and about to do is to help to implement a locally adopted version in other centers that reach out to us or that heard about this project and got in touch with us. And we're hoping to learn from obviously our experience, but also others' experience to further improve. So it might be that that other centers come up with ideas that we didn't think about, and so we can maybe then adjust and adopt and improve our bundle and our implementation. So ultimately, this will benefit more patients. So in summary, prevention care bundles can be developed for cardiothoracic perioperative care. They can be tested and implemented using the model for improvement method. They can contribute to improve adherence to best evidence in day-to-day clinical work. And a collaborative approach to implementation, sharing experiences with other departments and centers and learn from each other is of real advantage. And I mean, I'd like to emphasize, it all sounds and Dylan said, you know, it's quite a simple project. It might not look that simple for someone, for some of you who've never done a quality improvement. And a bundle is certainly not the first project that you start with, and certainly not the most simple intervention. It usually tackles, as I said, a multifactorial problem. And also, it sounds as if we've done almost everything right, and it went all smoothly and all very, very well. But obviously, well, and all the team members can probably tell about this. It wasn't as smoothly as it sounds like when we were presenting. So we did have problems initially. We did change ideas and the way we're doing. The nice thing about the model for improvement approach is that it does allow changing a plan. So it is, again, not research where you have to have, you know, once you've decided on how to conduct your study, you have to stick to it. Whereas in quality improvement, you can always change, add, adopt, adjust, maybe redefine your measures if you think something doesn't work. And when we did that data collection, came across some hurdles or other things that we had to change our minds about and change the way we were doing compared to what we initially planned to do it. So it is very normal that it doesn't run smoothly, and also obviously there are things that you can't control, and sometimes you're lucky because it's the right time and people are interested in that, or unlucky because there's a COVID pandemic coming across your way. So you have to abandon and restart from scratch. And the important thing I want to encourage everyone is to get started with something, and even if it's a very, very small project, so that's what the IHI encourages everyone to do. Even if you start with 5 patients in your department and start with something that you think we could do better, and it might be very, very minor, but even if it helps 5 patients, it's a great achievement. And then the next step you can take it to 10 more patients, and then more people will get interested, and then you'll build up a team. So you don't need to start with a massive team with a massive number and with a very shiny idea, but the small things that matter. And that's also why we called our project we gave it the title of doing simple things well. So it's about simple things that aren't always done as well as they could be done. Thank you, and I'm looking forward for questions and the discussion.
Thank you very much for sharing the details of your project, Dr. Bursch, and there have been some questions that have come up throughout that, if I may, and one of the first one links quite nicely to your closing statement there, and that is, in your experience, what is the best way to facilitate compliance with the care bundles?
So in my experience, the crucial thing really, and I think we will keep talking about it, but it's just so important, is the team approach. So it's not going to work if just the doctors think this is a good thing to do. It's just not going to work. So you have to have buy-in from everyone who's involved, and whoever that is in that specific area. So in our case, it was IT nurses, pharmacists, surgeons, as well as anesthetists and intensivists, and yeah, this is really, really crucial. Otherwise, one group of people will do it, and then once they leave, or as soon as that they move on to another location, it will just not be continued.
Thank you. And as a second part to that question, how can we ensure that the care bundles are adhered to and are not just treated as a tick box exercise, considering how important and relevant they are? Yeah,
that's a very good question, and we all know that we need to have quality improvement projects in our CV and all that. So again, I think a team is again crucial with a common goal, which is not just we want something for the for our CV, but a goal that is relevant, to patients. A team that really wants to make a change for a patient. So even if someone then loses their motivation or they don't have too much time, or someone does want to do it predominantly for their CV as a tick box exercise, there will always be other team members who step in, who can motivate the others, and it just creates a sort of dynamic, and equally the continuity that makes it, that prevents it from just being a tick box and then we don't talk about it the next 3 years because we've done it. Also, I think what is important and probably not done very well in many departments is there's some sort of cross-checking the projects that are being done and submitted, because I think, yes, a lot of projects are probably submitted as sort of tick box exercises, but if you've got someone in the department who's got an overview, who can actually discuss or even reject, not probably reject, but just discuss these projects that they feel aren't very relevant, or they suspect them to be a bit of a one-man show to enhance someone's CV, that gets recognized and addressed.
Thank you. I think that's important, and I'm sure that people will be able to take that away. I can see that Dr. Wells is here as well. So I've got a question here that might be relevant for both of you, and that is, in our centre at University Hospital Southampton, they have 2 prescribing platforms between cardiac ICU, and they've mentioned the CIS, Metavision, and our CHDU cardiac wards, GAC. How can we ensure that beta blockers are not missed when patients move between these areas?
I think it's certainly a unique problem that, and digital prescribing can give us such wonderful advantages, but this would be quite a tricky one. My advice would be for something auxiliary that come through in the patient's files. We have these perioperative checklists all the time where we go through, have we done the World Health Organization's safety checklist? And you could have something like that on discharge from ICU or moving to an HCU environment. Have we got the TEDs or the compression stockings? Just as we think about all the other things that are auxiliary to intensive care, you could add beta blockers onto that and say, have they received it, or has it been considered and indicated or considered and ruled out? And that would be a nice way to keep track of it.
Oh, fantastic.
Just something to add. I mean, it's very challenging with these IT that is supposed to help us, but then makes things complicated if you've got different systems to work with. But again, I think that's why it is important in this case to not only educate the intensive care team, but also the team on the ward. So they should basically have the same bundle and ideas and knowledge about why it's important to continue and to give beta blockers, so that decreases the risk that beta blockers, prescription get lost if they know that they need to focus on that as well. So you, in this case, probably you have to expand your teaching and training to more areas and not only areas.
Okay, thank you both for answering that for us. There is another one here. What about adult congenital heart disease surgery, dissection, etc.? Does this care bundle apply for them too, do you think?
So we didn't apply this to our adult congenital heart disease patients. As I alluded to, some of the patients, the mechanism of the atrial fibrillation is slightly different. And especially the adult congenital patients are an incredibly complex group of patients. And in our center, they kept under quite tight management with surgical teams coming from another hospital who traditionally work in the childhood side. And it was going to be a lot to try and integrate this bundle with all of their complex management initially. I think it's certainly something that could be looked at in the future, and it might be something that does provide a bit of benefit, but it wasn't part of what we looked at.
Okay, thank you. I think we've got one more question, if we can, to both of you. Regarding fluid balance, what's the target that you have in mind does that change with comorbidities such as heart failure and also as post-operative days advance?
Yes, definitely. I mean, there is unfortunately no clear evidence of tight numbers of targets, and that's why they're not in a bundle. That's why they're nowhere, and that's why there's, and I think that's why where your question comes from. There's a lot of discussion. That's one of the things that are most discussed in a post-operative, immediate post-operative care of the patients. And yes, certainly it's individual and needs to be individualized to the patient, and certainly different for someone with severe heart failure, and it does change over time. So we're not using negative fluid balance targets on day one, but obviously we're targeting negative fluid balance as we go along. But unfortunately, and I think it will make all our lives much easier, and with less discussions and arguments about it, if there were clear if there was clear scientific evidence what numbers should be targeted, and unfortunately there isn't. So the only thing that we can advocate for is to to let people think about it, and then follow a box and something, but it needs to be thought through for every patient and discussed for every patient. Unfortunately, there won't be any black and white and easy answer to that anytime soon, I'm afraid.
Thank you. Thank you to both of you for your presentations. Hopefully you can stick around for a little bit longer until the end for the panel discussion. Before we get to that, we've invited 3 nurses from Bart's ICU to come along, some of your colleagues, to share their experiences of implementing the project. And therefore I'd like to hand over to Cheryl Uwe, Jan Pearl Bongat and Mary Jane de Guzman. Thank you very much. I'll hand over to you.
Hi, good morning. Oh,
good morning. Thank you very much for joining us today.
Yeah, so part of the implementation of the nursing care bundle, I'd like to share my experience as a bedside nurse. So first of all, it feels so empowering to just be able to directly manage patients who are having AF through the care bundle. The accessibility and convenience, and most of all, the golden time that we save to prevent complications of AF have all been essential in dealing with these kinds of patients. I have also experienced sharing this with some junior nurses while leading the bay when a post-op patient went into fast AF in the middle of the night. I would immediately think about using the care bundle as a bay lead because it has direct and simple guidelines on what to do first, even before doctors come and review the patients. And also, I felt safer knowing that there is an AF care bundle that we follow in managing these patients. And we have seen firsthand what the effect of the nursing care bundle to the patients undergoing AF post-cardiac thoracic surgery. That's why I felt the importance of adhering to the care bundle myself. And also it allows us to actually be empowered to prompt the team during nursing ward rounds as well, to start beta blockers and to consider them in the review.
Yeah. Hello, everyone.
Hello, thank you for joining us today.
Yes, I don't know if you can hear. Oh, you can hear me now. My name is Mary Jane. I'm also one of the nurses over at St. Bart's. As for my role, I'm one of the NIC, or nurse in charge over there. So I would say being empowered, just like what my colleague just said, is one of the things that has this AF care bundle has given us, and being more proactive. Being on the shop floor as an NIC, one of the things that to make sure is these things are being implemented. And I would say that everyone's on the team is on board, particularly on day one itself. The AF Care Bundle has given us more confidence, especially the juniors. And just like what Dylan said in regards about because it's a big unit, so in ACCU, the uptake for junior doctors, not only the junior doctors, our colleagues and junior members of the unit, we have to share information by teaching, education, as well as giving them support as far as these guidelines if they feel a bit hesitation at first. But because of this AF Care Bundle, it gives us some safety net, and everyone's on the same wavelength as far as being proactive on implementing it. And that's the thing I can share as one of those nurses on the shop floor, and quite proud of it as well, because knowing that it has more good effect as far as the outcome for the patient.
Thank you very much, Mary Jane. I'm wondering if Cheryl's there as well. Did Cheryl want to join?
Oh, yes. Hello. Sorry, I'm at work. So my name is Cheryl. I'm one of the nurses in charge of St. Bart. So I think I'm just going to discuss about the challenges, or the one when we first initially implemented the AF Care Bundle. I think it's more of the nurses' hesitations to actually give the beta blockers, especially when they're still on noradrenaline infusion. So after we've actually had that kind of low compliance in that one, so we did further like education with all the nurses, especially the core teams in each unit, apart from having those posters and on their bed spaces as well. So we just need to actually like re-educate about the criteria, because it's all like more specific in the bundle, like the criteria can give your beta blockers. And since after that re-education with nurses, so everyone's actually like the compliance is really good now, and that hesitation is actually gone. They're like more empowered to give the beta blockers. All right, thank you. And I have my colleague in here who will share something as well.
I don't know what to share. Yeah. Hi, good afternoon, everybody. My name is Raquel. I'm also one of the nurses in charge in ACCU. And to add on the challenges that my colleagues had experienced whilst implementing this AF bundle, I agree with Cheryl. So initially, there was a problem with, we were not sure about when to start prescribing bisoprolol. If the NORAD, for example, was, let's say, sitting at 0.06, we immediately think that, no, we can't prescribe bisoprolol, without thinking that actually it would go down most probably, or it's a winning dose, so we should just prescribe it in the drug chart. So that was the dilemma to start with. And yes, so another thing is, for example, the heart rate. If the heart rate is, let's say, 60 beats per minute, but we'd have a pacing wires, we have to be empowered to say that actually we have pacing wires on, it's connected to a box. So I think we should just give a little bit of bisoprolol here of 1.25. It wouldn't do any harm to the patient because we are attached to pacing box. So, but at the moment, currently, after all this challenges that we've faced to start with, we are actually very good now at, even today during ward rounds, automatically it was all on everybody's head. So the doctors would automatically prescribe it. It's the first thing that we look at. So we have no problems with our implementation at the moment when it comes to beta blockers. But there are other issues in this bundle that is at the moment we are actually looking at, like, for example, pain. We haven't looked at that, so optimizing pain. So there are other things, but when it comes to beta blockers, I think we have overcome the issues that we've had to start with. That's it for me. Thank you.
Thank you very much to all of you. I just want to share with you all before we move on to the questions that there's been lots of just general comments about how everyone's enjoyed listening to your presentation. So it's been wonderful, and what I think has been particularly great is to have colleagues who are clearly at work at the moment but coming in and sharing their experiences, because I think that will translate through to different areas and people that are watching today. So thank you very much. I have some questions that to open out to all of you, if that's all right, that have been coming through, and hopefully I get them all. If not, please do feel free to raise your hand or come into the questions as well and ask them directly. But we have one about what is the best practice for beta blocker dosing frequency, and they've said once daily or twice daily. That's from Lyrill.
You can just step into this. It's not an easy question, and I don't think I've got the answer, unfortunately. But I think there's just not evidence on what exactly, which beta blockers exactly to use. I think different studies have used different drugs, and that might have been because of their institutional normal practice or because of the availability in the respective countries. So what we do is we start with a small dose, and usually it's bisoprolol. I'm not saying that this is the perfect drug for this, or you should be using this, but I think here in this country at least, it's readily available. It's given to many patients who are given beta blockers before surgery. They are actually on bisoprolol rather than other beta blockers, but that might be different in other countries. So that's why. And we tend to use bisoprolol. We start with a very small dose if we are in doubt. And normally we do start with a small dose. Even if a patient had been on 5 milligrams, let's say, BD, we would still start with half of the dose or even less, because there's no harm up titrating as the day goes on. So you start with 1.25 at 9 in the morning during the ward round, but then maybe if the blood pressure and the heart rate are stable and the patient is all right, we will gradually give more during the day and then maybe build up to the normal dose or close to the normal dose. And I think the data support that whichever dose you give, it is better to give. It is better than giving nothing. So even a small dose will interrupt this cycle of withdrawal of beta blockers for patients who've been on them, and help preventing AF. So the important thing is give something. There's also a bit of a debate about what to do with patients who can't swallow tablets because they're still intubated. Should we put in an NG tube to give them? Should we give some IV beta blockers? We've decided not to put that into the bundle because there's so much discussion about it and not clear evidence. Most patients who are not extubated on day one, usually there are some other underlying problems, and they will probably not qualify for beta blockers anyway because they are unstable. They've got a lot of inotrope on board or other issues. So certainly there is room for further research. I think this is a domain for further research rather than forcing things that we're not quite sure about. And then that might be disappointed because they're not working or creating more difficulty.
Well, thank you. That was one that there wasn't quite a straightforward answer to, was it? It seems that, yeah. So sorry about that. We're bombarding you today, but obviously everyone's interested in your chat and generated lots of questions. Another one that's come through is, did you consider oral electrolyte replacements once central access has been removed?
We definitely did. And when we didn't have central access, that was our mainstay of replacement. So Slomag or Sandicay was certainly what we'd use once the patients were swallowing. Once they were eating and drinking, they were also taking the bisoprolol orally, like Martina said, and I think that was really useful as well.
Brilliant, thank you. And as far as I can see, there's one more question, unless any more pop up while you're answering it, and that is, Carol's asked, is there a similar AF bundle used for thoracic surgery patients that you know of?
There's none that I know of, and I think the issue of AF in cardiac and thoracic surgery, it is frequent. It's more frequent than in non-cardiac and non-thoracic surgery. However, it's still not quite clear what the mechanisms are, and there's some discussions about the right ventricle being the problem, which is sort of impaired during or after thoracic surgery. So I'm sure it is different mechanisms than the post-cardiac surgical atrial fibrillation. And although there is research about this, I don't think, as far as I know, there isn't enough evidence to support any of the prevention strategies that's been discussed for cardiac surgery. So I don't know of any funding for that.
Okay, thank you very much. I understand that JP, I think, is raising his hand, and I think that's got to be the last question given the time. I don't want to interfere with your lunch. JP, did you have a question?
It's a very quick one. First and foremost, congratulations to all the implementers. My first question was basically to the panel around, did you record any patient safety incidents, although you have a very uptake on this implementation? And then the last one is for the people who implemented on the ward. Did you notice if there's any significant difference of compliance from coming from critical care going to the ward area?
Okay, let me have a go on this. So the first one is the complications, and I think as Dylan said before, we didn't record complications such as bradycardia, and that's certainly something we could have done probably. The reason why we didn't, and so just to say, I mean, our feeling and our teams and the people who are not involved in that feelings is that it's not a big issue, and there isn't a significant increase that we can see or feel. And then as you heard from various IC nurses, it's actually quite very well accepted, and that means that the side effects might be quite small. And one of the reasons we didn't attempt to record this in detail is it's a treatment that's been extensively researched, and where these trials have been done and looked at side effects and benefits versus problems. So we felt we could, for this project, we could skip this bit because other people have already done it.
Yeah, and to add to what Martina had said, I think the advantage of our unit is we have an integrated drug chart that we could carry from ACCU to the wards. So if the prescription is already there for bisoprolol, then they could review it in the ward whether it's appropriate to give it to the patient or not. So I think that's one of our advantage here. But it's not electronically prescribed yet. So it would be nice if it's also electronically prescribed. Thank you.
I like the request in there at the end. Excellent. Thank you very much to everyone. I'm conscious of the time. Thank you to all of you for your presentations today. They've been very well received, and I'm sorry that we've ran over. We've got lots of questions for you, and also to our colleagues who have come to share their experiences with us. I'll close the session now, but just to remind you that we're starting back at 1:30 after lunch, but the room will be open again at 25 past, ready to start promptly at 1:30. Thank you very much for your time today. Hope you enjoy the rest of your presentation. And if anyone's got any feedback or comments about the day, we'd be really keen to hear about it, because as you know, we've mentioned it several times. It is our first university day, and we want to hear things that you enjoy. And if there's anything that you'd like to do, hopefully for the second one next year, that would be great. Thank you very much.
Thank you, everyone.
Thank you.